Make sure that you're reading through this, back through this. Notice how my book is nice and highlighted. Okay, so I'm there, right there with you. We just went over, edema, observation, weight of the patient, removing IVs, sterile dressings, aseptic stuff. Okay, which we will continuously review. Okay, this Wong-Banker's faces rating scale here is just how they mainly used in pediatrics. Okay, so they'll show a kid these faces and say, hey, how did you feel? Most adults can understand the 1 to 10. And on a larger one, there's 10 faces. Okay, so most adults can sort of figure out, hey, which on 1 to 10, they understand that rate. Children, they need faces. So when you woke up this morning, you come back to school, you were here, right? And an 8, if not worse. Right? The other thing, the next thing that goes into is blood pressures and vital signs, pulse oximetry, measuring respirations and pulse, and we're good with that, right? There shouldn't be any problem with that whatsoever. It does mention an apical pulse in here. An apical pulse is what? 26, page 26. An apical pulse is the one that you listen to. There's a measurement of intercostal space that you would put it over, but here it is, a 5th intercostal space. Okay, thanks for the highlighting. But you would place that about right here, really, because that's where the left ventricle is. Apical or apex, that's where the apex of the heart is. A lot of times on babies, you would get an apical pulse. You would listen for it, full minute, for an apical pulse. So you take your stethoscope, you put it in that 5th intercostal space. Okay, if I can't palpate mine right there because I have too much fat, but on a child that's real thin, they don't have a lot of fat yet, you can palpate that pulse. But the best thing is to put your stethoscope there. When it talks about a deficit, there's a deficit between the apical pulse and the radial pulse. That is something that you would report to the nurse. All right? Hey, there's a deficit there. Most things that you're going to encounter, that if it's wrong, then you'd report it to the nurse. Okay? We'll go into a chain of command sort of later, but that's what you would do. If you have anything that's abnormal, then you would report it to the nurse. All right? Everybody understands pulse oximetry, right? Pulse ox, doing that. 94% and above is good. Below 94%, we need to evaluate the need for oxygen, right? Part of your job as a PCT is going to be direct patient care. You guys have seen the nurses, right? They don't, a lot of times, especially doctors, they don't have direct patient care. So you're going to be the ones that see the patient the most, that do most of the procedures, okay? So you need to make sure that your conduct with the patient is professional, that they know who you are. Introduce yourself, right? Always to the patient. Introduce yourself. Tell them what you are, like you would say, hey, my name's Randy, I'm a high school, well, for me, I would go in, and if I was going to introduce myself, I'd say, hey, my name's Randy, I'm the high school teacher, right? I'm with everybody else that's in dark blue scrubs, okay? Or if I was a PCT, I said, hey, my name's Randy, I'm your PCT today. I'm going to be leading these procedures, okay? So make sure that you introduce them, and as we go into phlebotomy in the next week or so, explain the procedures. So if you're changing that dressing or whatever, then you would explain that. All right. With having direct patient care, okay, you're going to get orders. requisitions or orders, medical orders. So they enter it to the computer. Let's say you have to go draw a lab. They're going to enter it to a computer, and it's going to print up an order for you to look at. Okay? You would take that order and you would verify it that, hey, this is what I'm doing. I'm drawing a lab. Make sure that's in your scope of practice, right? And then you would look at indicators. Most hospitals, most facilities have 2 or 3 identifiers. Their name, date of birth, and then you look and compare it to the order. John Smith on the order, then I'm talking to John Smith, right? Have you been in the room when they say, hey, what's your name and date of birth?
Mm-hmm.
Yeah. They're doing this. They're verifying that it's that person. They're comparing it to the order that they have. Most all places is name and date of birth. Okay? So you compare the order to the name and date of birth, make sure that you have the right person doing that. Okay? If there's more than one of the same name, you just get a name alert on it. Hey, there's 2 John Smiths here. Don't get them confused. That's happened to me before. I drew blood on the wrong person. Whoops. But when you do a sample, like and again, we'll do this. If you have I know that this doesn't look like a blood tube, but let's say blood's in there, right? Okay, you would, on the label, you have a patient label, and what you'll put it on the tube, okay, with that patient's name and their identifiers over there and their hospital record on there. So what you would do is you would put your initials on there, the date, the time, okay, and the date. I don't know the date. What's the date? 8. Right. Without those 3 things on the tube or on the order, urine, whatever you're collecting, okay, lab-wise, they're going to throw it away. They won't take that unless that is on the specimen that you've taken. Your initials, the time, and the date. It's not usable, okay? We'll get into this thing when we're talking about the chain of custody, and a lot of that has to do with, like people having crimes. But if I go draw somebody's lab, I can't set it in the room and walk away. I keep it with me, okay, until I send it to the lab. Right? That way it goes to me and to the lab. Right? Informed and implied consent. Now this is a little different. Implied consent on the PCT side is our implied consent I've been teaching you so far is that unconscious person or that person that's not ANO times 4 or that person that's under the age of 18, right? That would be implied consent. But in the PCT world, implied consent, like one of the questions may be, hint, hint, one of the questions may be that the patient sticks you want to take their blood pressure and they stick their arm out and like this. That's implied. I'm implying that it's okay for you to take my blood pressure. All right. Where we learned it was expressed consent. Okay, but that's under implied consent. Everybody good with that? The other thing is informed consent. So if you're going to do a procedure on a patient, then you would inform them of what you're doing, what the procedures are, the risk, okay, and to get their permission to do the procedure as well. That's it. When you go into the room, since you have direct patient care, and let's say that you're going to draw a fasting glucose level, okay? Fasting means that they haven't eaten yet. So you're going to draw that level, and since you have most of the contact with the patient, you go in there and all of a sudden you see the food tray empty, right? Or you see food in the trash can. You have that good situational awareness in your observing things, right? That sort of size up for that. So you walk in there and you go, oh, there's a Cheeto bag in there. Did you eat those Cheetos? And if they say, oh yeah, I couldn't hold out, I had to have another Cheeto. And then you can't draw that fasting glucose, right? So what would you do?
Inform the nurse.
There you go. You go inform the nurse that, hey, John Smith ate some Cheetos. Well, you might see an empty food tray or something that looks like they've eaten, okay? So, or you see evidence of that they've eaten, so they're not fasting, okay? In 6 weeks, we'll do EKG interpretation. Okay, we already sort of start some basic EKG interpretation, sinus rhythms, AFib, so we're somewhat familiar with that. We'll go into a lot more in the future. I knew I was getting some. Okay, so vital signs, temperature is part of it. Blood pressure, temperature, pulse, respirations, right? I think that's hilarious. The last time I actually counted respirations. So because we know that normal people, like if you're sitting there and you come in for a procedure, you're not in outward respiratory distress, I'm probably just going to estimate the respirations at 16 because most everybody breathes about 16 to 18 times per minute resting, okay? Pulse oximetry, we look at this. This is where you would put your stethoscope for the apical pulse, all right? And then sort of the finger probe or the little ET finger for the pulse oximetry. The different bands on the patients, okay? So they may have different risk. They may be a fall risk. All the hospitals have different color bands, right? Allergies, wristbands always red. Okay, so this probably has the patient's name and date of birth and hospital number on it. So look at that at least minimum 2, name and date of birth, and then like we talked about, compare it to your order and the test that's about to be performed. Some people, if they're having all of a sudden, I go to the doctor and I say, man, boom, 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 I can feel your heart jumping out. So I have these palpitations, and it feels like my heart's really racing. What they will do, Holter monitoring, I go into their office and they'll put this monitor, actually the PCT will put this monitor on, okay? And then somewhere in a dark room somewhere, somebody is monitoring that, okay? This shows up on an EKG machine somewhere. So let's say this somewhere is in, it could be anywhere. It could be in San Antonio or whatever, right? Let's just say it's in Dallas. So somebody's in a dark room, they're watching the EKG monitor, and this particular Holter monitor is identified as me. All right? So I start having a tachycardia, and it records that 24 hours a day. I leave it on, okay? And it records that, and then records how many times I have this tachycardia, and if it's really bad, then that person that's doing the EKG monitor will call the doctor, say, hey, John Smith's having this tachycardia again, and then they'll get a hold of me, right? And so anyway, they leave it on 20. We notice why it's just an EKG. It's just transmitted to a facility, and so you would place the electrodes on Make sure that they don't have any reaction to the pads. Okay. Tell them to wear this during their normal daily routine. And if the electrodes fall off, call the doctor so they can place the electrodes back on. And then if there's an emergency, like the patient have this tachycardia, and I get a syncopal episode, then I want to call 911, right? For sure. Sweating, chest pain, anything like this. This is a potential job for you guys, not only to do this, like work in a cardiology as PCT for the cardiologist, but also to monitor these in that dark little room. Okay, so that's something to look at as well. Is the Holter monitor. Have you ever seen anybody wear one? Yeah, usually they're under the clothes and you can't see them. Okay, but they're having some cardiac event, some non-life-threatening cardiac event that they just want to monitor and see what's going on. Okay. The other one is a stress test, and what they're trying to do with this stress test is reproduce the cardiac event. Whatever the cardiac event was, they want to try to reduce it. So they're hooked, like this guy here, they're hooking him up to the EKG and the blood pressure and everything, and they're going to have him start walking at a certain rate on the treadmill and try to reproduce that event. Maybe try to reproduce that chest pain or something, right? Maybe try to reproduce some ST elevation. It's called a stress test, and it's done in the cardiologist office. So that's something as well, another avenue for you. The PCT would do this under the supervision of the nurse. Okay. The nurse is there. She's probably off in the corner doing computer stuff or on her cell phone checking Facebook or something. Who knows what they're doing. Making you do all the work. Anyhow, so stress test, there is a certain thing that's a chemical stress test that you wouldn't be doing, that they would put a chemical in and try to reproduce the cardiac event. Okay, but this is what the cardiologist would do there. So the same thing, okay? Tell the patient how long it's going to take, apply the electrodes, make sure they don't have any reaction to the stickers, okay? That they don't eat or drink or smoke 3 hours before the test. And if they have, the biggest thing is if they have any fatigue, any dizziness, any chest pain, any nausea, anything to go wrong, that they tell you. Okay, so Pops is on the treadmill there, and he's walking along, and all of a sudden he starts having chest pain. As a PCT, what would you do?
Report it to the nurse.
Report it to the nurse, but before you report it to the nurse, what would you do?
Write it down.
He has it all, probably all hooked up to him. You can see it. Think simple. I'm walking on the treadmill, I'm having chest pain.
Sit him down.
Huh?
Take him out, sit him down.
Right, stop the procedure, right? Stop the procedure, set the patient down, get the nurse, right? You stop the procedure. Okay, so abnormal heart rates, pressure drops, anything like that, you would want to stop the stress test. And then there's this dark little room right there. This is where this guy here, he's a Tele Monitor, and he's monitoring all these cardiac rhythms. You'll see this on the first and second floors, okay? I mean the second, third floors. They've got there's a space in the hospital where we eventually get to next 6 weeks where you see the telemetry monitors. This is another potential job for you as well, okay? It's because you learn EKG interpretation. So you sit there and you watch these monitors. It's sort of a boring job, but if the tech or the PCT hooks them up to the monitor, and this monitor tech watches the rhythms, and if they change, then they call the they call the floor, they call where that patient is, okay? And then, and they're all alarmed. So if the rhythm changes too much, there's an alarm that goes off, so a person would look up and go, oh, they're just moving, or they just rolled over. And you learn all that stuff. You can discern artifact from cardiac rhythm. These are the sort of the non-critical patients that Tele. You may have already seen that where they put a Tele box on them and they take them up to the floor. 4 leads, 12 leads. You have any questions on how to put the leads on? All those kids, right? You put all those leads on them. So we'll make sure that you understand where the leads go. The same way with 12 leads, we'll all get together. We're going to go over to North Mesquite for the OB delivery, and they have a 12 lead. So everybody's going to practice. Whilst one group is delivering a baby, another group is going to practice putting on the 12 lead EKG. Don't get the 12 lead EKG confused with the 4 lead. Okay, the 4 lead is a monitor, right? Monitor quality. And so they're monitoring that. So the 4 leads would go here, and they can go down on if they're just doing a cardiac monitor, they can go down on below the rib cage here. So the red and the green lead can go here. If they're doing a 12 lead, then they go towards the feet. So don't get a 12 lead EKG mixed up with the 4 lead EKG. Okay, a 12 lead EKG is a diagnostic tool, and we'll break that down even further as we go along and figure out how to set all that up. Okay. Pediatric right ventricle is dominant. Okay. They have a different axis and order for you. You don't have to make this decision. The doctor say, "Hey, I had this 10-year-old. I want you to go in and do this." So instead of V1 going on the left side, V1, V2, it would be flipped around. So V1, V2, right? And then the other 3, 4, 5, and 6 would go around on the right side. We have a normal axis. You know what an axis is, right? The Earth sits on an axis. Okay. Your heart sits in the chest cavity, the mediastinum, on an axis, and it's about -30 to 60. Here, 90 degrees. So it's -30 to about 90 degrees, the normal axis of the heart. All right. If there's a deviation to that, it's called axis deviation. If you were to lay down, which most of you would want to do right now, right? If you lay down, you change the axis deviation of your heart. Someone at CHF, they may have a drastic axis deviation due to the overstretching of it. Most of the time, it's not a big deal, okay? But that's really why they do, on a pediatric patient, they do a right-sided 12 lead. This will make a lot more sense after we get up and practice putting that 12 lead on, okay? Some of you already mastered that, correct? So it's not very hard at all. Make sure that when you're taking care of these patients, you have direct care over these patients, that you look for changes, right? You look for trends. So you have this patient that you're going into the room and you're talking to them, asking them how they're doing. Can I get anything for you? Just like you may do on the second, third floor, right? And all of a sudden you see them, they're all pale and diaphoretic. What would you do? The last time you were in there, they were warm, pink, and dry. This time you went in there and they were pale and diaphoretic. What would you do? Tell the nurse, right? Go tell that nurse. Quickly. Okay? So, you notice this is why we look at these signs and symptoms over all those medical emergencies that we went over, okay? We have different signs and symptoms. So we want to make sure that you're aware of the different signs and symptoms. Right? And if there's a change, then you would make sure that you inform the nurses of the change. Here's the 12 lead. So a 4 lead, right arm, left arm, right, or the white one and the black one, set up here in the pocket or on the deltoid, not on a bone, but on the deltoid or this little pocket here. And if you're just doing the monitor, okay, if all you're doing is monitoring the EKG, then they can go down here on the blue belt right here, okay? Otherwise, if you're doing a 12 lead, they need to go down on the ankles, preferably on the inside of the ankles, okay, at the same level. It deals with the vector of the way that the machine reads, and if you get the leads in the improper place, it can produce maybe a false ST elevation or something, okay? On the 12 lead, on the V leads, this would be the 1, 2, 3, 4th intercostal space. Remember the rib, your clavicle. Everybody palpate their clavicle, okay? The first rib is under the clavicle. You can't feel it. The first rib that you can actually palpate is your second rib, okay? So in the intercostal spaces, it's down here on V1 and V2. What I do is I put V1, V2 here, and you just get used to where they go, because V4 goes right under the nipple, okay? And then I take V3 and just put it between V2 and V3, okay? Then I put V6, because V6 goes in the mid-axillary, okay? And then I would put V5 there, in between V4 and V5. Just as a, and as more that you do it, it's an easy thing to do. It's just the more you do it, the more you get comfortable doing it, okay? I know what everybody's thinking. If you have maybe a female patient who has large breasts, right?
Yeah.
You have to move those out of the way, okay? Females, maybe not, maybe a little awkward, but not as big as thing. A male, what would you do? No, because they're saying, get in there and do your job. What would you do?
I might have
You would have to explain to the patient what you're, ask. Explain to the patient, says, hey, this lead goes underneath your breast, okay? And of course, an older person, but so you ask them, say, hey, this goes under your breast. So you would take the back of your hand and lift the breast up, and then put the electrode in there, okay? Don't like, okay? Just move it out of the way, but do explain what you're doing to the patient. Now, guys, males, if it's a young female patient, then I would probably go try to get a female nurse to do it, okay? If it's a minor, and there's like no female nurses, nobody could do it, then I would absolutely have the parents in the room, and probably them supervising a little bit, okay? You still have to do your job. It doesn't matter the anatomy, right? So you still have to do your job, but make sure that you're thinking about that, okay? Informing the patient of what you're doing, and just think about it, you know, like, think way in the future, if this was your daughter in there, how would you, okay? So, so applying the 12 lead, we'll get plenty of practice doing that. Here's the right-sided one. Say where you have the V2 and the U. Right? So we have to think about this one a little bit. But the posterior view, this would be the V1, V2, then around from the back. We do 12 leads, but now they have 18 leads out, and they have posterior view. They have to do a posterior 12 lead. I've seen it in the hospital that where we go, and so that's something that they have to do as well. Okay, we're gonna have to stop here. Because we're out of time.